నాకు will restart.
Yes. So, Karthik, you can go ahead with your presentation. Once Dr. Vivek joins, then we'll ask him.
Yes. So, with this discussion of term baby with a AV malformation, we will have a little recap about AV malformation. What are the clinical staging of AV malformation and classification, various classification available in diagnosing AV malformation. So, as we all know, arteriovenous malformation, basically a connection between the arterial veins and the central nidus, and there is a bypass with high resistance of the capillary beds and the high flow lesions. So usually they are present 40% at birth, and there is a clinical staging called Schobinger clinical staging for classification of this AV malformation, which includes 4 stages. The stage 1 is quiescent stage, where there is a pink bluish stain, warmth, and arteriovenous shunting, which is revealed by Doppler. And stage 2 is the expansion, which is same as the stage 1, but there is an enlargement. You can appreciate the pulsation, thrill, and bruit. So stage 3 is the destructive stage, where there is dystrophic skin changes, ulceration, bleeding, and necrosis, and osteolytic lesions may also occur. And the stage 4 is decompensation stage, where there is high output congestive heart failure, as well as left ventricular hypertrophy. So this basically stage 1 and 2 is for the initial diagnostics and follow. Stage 3 and 4 for the definitive treatment. So always you have to look for the progression in this AV malformation. They require treatment in adolescence, usually then childhood. And there is a risk of progression before childhood also. There is 82.6% risk of progression before childhood. So basically you have to monitor this child on long term. There is something called CHOS classification based on the DSA, which is angiographic classification, where you have type 1, 2, 3, and 3A and 3B based upon the angiographic findings. So in histology also, in AV malformation, you can see abnormal arteriovenous communications, of the arterioles and capillary venules aggregated in the vascular clusters. And you can see abrupt dilatation and changes in the vessel wall thickening. In veins, you can see reactive intimal hyperplasia, and the adventitia and the adjective connective tissues are fibrosed. So we have to differentiate these hemangiomas as well as AV malformation. Basically, these hemangiomas are typically, they lack arterial and the arteriolar structures when compared to, and intralesional nerve fibers when compared to AV malformation, which they have arterial and arteriolar structures, and there is a communication which is present between the two. So AV malformation basically is a multidisciplinary approach. So a team of neonatologists, vascular surgeons, interventional radiologists, plastic surgeons. So all of them, they are involved in the treatment. So it is a multimodal therapy which include pharmacotherapy, minimally invasive interventional therapy, so which mainly includes debulking and as well as the size reduction of the vascularization of the AV malformation. And lastly, the surgical therapy, which is the most definitive, where there is a we go ahead with a complete resection with the goal of entirely removing the nidus. So there is something called revised Richter Swain classification system for extracranial AV malformations, which can differentiate the focal AV malformation from the multicentric AV malformation. In focal, the central nidus will be present, but in multicentric AV malformation, it is very difficult to find the nidus. In focus, we have single arterial feeder, whereas in multicentric AVM, we have two or more arterial feeders. On palpation, it will be firm, whereas in multicentric AVM, it will be compressible, rapid, and rebound. And the singular skin involvement are present in focal, whereas diffuse skin involvement is present in the multicentric AVM. So the definitive treatment is the resection, but the initial modality of management will be, the first line of management will be embolization. Percutaneous or transarterial embolization is the first line of therapy in case of any AV malformation. So we have discussed the lot of various agents as well as complications associated with them. Second thing is the surgical, that is resection. So after the complete occlusion of this nidus using the glue or sclerosants, so we can consider for resection. Third thing is the percutaneous direct puncture of the nidus. As in our case, which is a neonate, where the femoral approach will be difficult, we have considered the percutaneous direct puncture of the nidus. So there are various agents like ethanol, N-butyl cyanoacrylate glue, onyx, and coils, they have been tried. So most commonly, N-butyl cyanoacrylate glue have been used previously in the literature also, and in practice also for glue embolization. And as a complication, we should see post-embolization, there are revascularization rate, which is ranging from almost 12% to 18% in the embolized vessels. So these are the complications which one should expect after embolization. And coming to the morbidity and the mortality rate, there have been various previous literature which has shown that the morbidity and mortality rate in these cases of AVM, it will be as high as 17% also, as well as mortality rate is 0 to 2%. So now I will hand over my discussion to Dr. Suprabha madam. Yes, ma'am, you can continue.
Unmute. Yeah. Take. So thank you, Karthik. And I think we have lost Dr. Vivek is not there with us. So we'll just continue with to recap today's presentation, as all of us would have recognized that it is very important to first identify a vascular anomaly and then categorize it into either as a vascular malformation or a category of a vascular tumor or hemangioma. And for the diagnosis part, imaging, it has plays a very crucial role. And as we can see in this table, that as per the type of flow, the flow characteristic, various modalities, imaging modalities can be utilized, and with a various degrees of diagnostic outcomes. So in case of, like in this case of AV malformation, we can see that the color Doppler scan, the diagnostic outcomes are as good, I mean the best, along with the CTA if feasible as per the patient's age and feasibility of doing an angiography. So accordingly, according to the flow related spectrum, the various modalities can be utilized. Next slide. So as again to re-emphasize the goals of treatment in a case of a vascular anomaly is reduction in size and the associated symptoms with it, not a total cure, which is very, very difficult until unless it is a very localized lesion, and multiple therapy sessions of different modalities will be required. An important thing is to achieve a patient satisfaction and symptomatic improvement and not just a change in the imaging findings. Next, please. So to sum it up, in a case of any localized swelling, first identify whether it's a vascular or non-vascular anomaly, and if it's a vascular anomaly, on the basis of imaging, identify whether it's a tumor or a malformation, and as per the underlying condition, we have to utilize the appropriate therapeutic option, whether it's a pharmacotherapeutic or a embolization or a sclerotherapy or a resection. So accordingly, a multidisciplinary approach for a case has to be taken up. So with this, we come to the end of today's session. If anybody has any doubts or questions, we can address that. Since we do not have any questions in the chat box, I would like to thank all our participants who have joined us for this session. And thank you, Karthik, for presenting the case. Thank you very much.
Thank you.